Good evening, ladies and gentlemen. First of all, I would like to thank the organizing committee and Servier for giving me this opportunity to share with you the consensus statement from the Gulf Cooperation Council on sulfonylurea, which was published in Diabetes Therapy this year. So this is my disclosure of relationship, and this presentation is sponsored by Servier. My name is Ibtisam Baisa. I'm consultant internist and endocrinologist from Dammam, Kingdom of Saudi Arabia. So as you all know, the prevalence of diabetes in the group of GCC countries is one of the highest in the world, and the use of sulfonylureas is widespread due to their extensive evidence of their efficacy and understanding of their risk, and they have been in use for more than 60 years, and they are also cheap and affordable. The discrepancies between international guidelines on diabetes mostly relates to the recommendation for second-line agents, and this is attributable to the concern regarding the cardiovascular risk and safety of sulfonylurea with the earlier generations, and the potential for body weight and body weight gain, as well as hypoglycemia. So as you know, we had the first generation sulfonylurea, which now is obsolete. They are not in use anymore. And we have the second generation sulfonylurea, glipizide and gliclamide, which are less frequently used. I know there are still some countries using them. And we have the newer generation sulfonylurea, glimepiride and gliclazide, which are most commonly used. The first generation sulfonylurea were introduced in 1950, and the second generation sulfonylurea were introduced in the 1984, and glimepiride was introduced in 1995. And as I mentioned, gliclazide and glimepiride is largely replaced all those first generation sulfonylureas. So this presentation summarizes the present and future role of newer generation sulfonylureas, such as gliclazide MR, in the management of diabetes within the GCC countries. So the GCC task force process consisted of two virtual meetings that was held in 2020 in view of the epidemic era. And the first meeting was held in October 2021. The task force members were assigned topics. For each topic, task force member conducted literature review to identify the most robust, up-to-date literature and relevant systematic review and meta-analysis. The second meeting were held in November 2020, and the task force members described findings of literature review, and an online survey of sulfonylurea use in clinical practice was also distributed among other experts and colleagues within the GCC region. And the literature reviews and survey responses formed the basis of the manuscript on which this presentation is based. And the article, as I mentioned, was published in May 2021. So I had the pleasure also to work in this group, and the main author of this task force was Professor Al-Saleh, where we had the pleasure to work with him. And also I had the pleasure to work with my colleagues from the Kingdom of Saudi Arabia, United Arab Emirates, Kuwait, Bahrain, Qatar, and Oman. This consensus was endorsed by the Gulf Association of Endocrinology and Diabetes, the Bahrain Diabetes Society, the Emirate Diabetes and Endocrine Society, and the Saudi Diabetes Society. The major themes of this paper included the introduction, mechanism of action, the long-term sulfonylurea efficacy and safety, the clinical practice research, data link, the CPRD study, the end organ benefits, cardiac and renal, the risk of hypoglycemia and Ramadan studies, the body weight gain, and then the conclusion. I will start with the mechanism of action. As you know, sulfonylurea differs in their affinities for sulfonylurea receptors in different tissues, such as the pancreas and the heart. And for example, if we take the second generation sulfonylurea gliclazide, which has the high affinity and reversible binding to sulfonylurea receptor 1, which makes it a unique sulfonylurea as compared to other sulfonylureas, especially the first generation sulfonylurea and the older second generation sulfonylurea. So the restoration of the early insulin peak secondary to glucose and the storage, the stronger reversible bindings of gliclazide MR to the beta cell sulfonylurea receptor 1 compared to other sulfonylureas could be responsible for the reduced pancreatic stimulation, which translate later to reduced risk for hypoglycemia. In more details, you can see here the link to the lower risk of hypoglycemia with gliclazide MR. As you know, insulin secretion from beta cell is glucose dependent, and insulin secretion depends on reversibility of binding to ATP sensitive potassium channel on beta cell. As you can see here, with gliclamide and glimepiride, the second generation sulfonylurea glimepiride, they combine the sulfonylurea receptor 1, but this combination is really irreversible. While with gliclazide MR, this binding to the receptor is really reversible. So that translates to the reduced risk of hypoglycemia with gliclazide, and you can see the highest risk for hypoglycemia is with gliclamide, and also amongst the second newer generation sulfonylurea, gliclazide have shown lower risk of hypoglycemia as compared even to glimepiride, second generation sulfonylurea. The potential also mechanism for variability in mortality risk between sulfonylurea, in addition to the reversibility of the binding, also the selectivity of the binding to sulfonylurea receptor 1. So as you can see here, gliclazide selectively binds to the sulfonylurea receptor 1, which is located in the pancreatic beta cell, while other sulfonylurea, they bind to other sulfonylurea receptor 2A and B that is located in the myocardial and the vascular smooth muscle cell. And that again will translate to the what happens with the older generation sulfonylurea, where they have an interference with the adaptive ischemic preconditioning and increase in the myocardial infarction side, which we don't see with the newer sulfonylurea generation, glimepiride and gliclazide, because of their selective binding to sulfonylurea receptor 1. Also, mortality risk among sulfonylurea, systemic review and network meta-analysis of 18 controlled trial that included a huge number of patients, as you can see here, revealed that the lowest risk occurred with gliclazide in case of all-cause mortality as well as cardiovascular disease-related mortality. So as you can see here, it is lower with glimepiride and gliclazide, and it is lowest with gliclazide. So let us now review the long-term sulfonylurea efficacy and safety with the newer generation sulfonylureas. I'll just only remind you about this important landmark study, the UKBDS. This is an old study that we learned from it a lot, where they have used in the intensive group, the sulfonylurea and insulin, and they demonstrated that sulfonylurea as well can result in significant reduction of A1C and achieving glycemic target and result in metabolic memory. So, while glycemic control in the cornerstone of type 2 diabetes management, long-term efficacy and safety are paramount consideration when declining on optimal treatment. And the risk and benefit of sulfonylurea are well documented given their established history. And in the advanced trial that included more than 11,000 type 2 patients with diabetes aged 50 and more, and what we have learned from this advanced trial, we learned that tight glycemic control with A1C less than 6.5 can be achieved and maintained for up to 5 years study period using a sulfonylurea-based regimen. In addition, tight control with a sulfonylurea-based regimen gave a 14% reduction in microvascular complication versus a standard therapy. As well, tight glycemic control with a sulfonylurea regimen was deemed safe and practical despite no significant reduction in macrovascular events or mortality from any cause. So let us review the clinical practice research data link, the CPRD study, and with the aim of to compare the safety and efficacy of gliclazide MR versus DDP4 inhibitor sitagliptin post-metformin monotherapy. This is a retrospective observation study using real-time primary care data from the UK in type 2 diabetes patients, almost around 2,000 patients treated for up to 9 years. And what it has been shown that the gliclazide MR was associated with 35% higher probability than sitagliptin of achieving target A1C of less than 7%, and which is significant, statistically significant, and also had similar durability and persistence of glycemic control when reported for both drugs. And the symptomatic hypoglycemia induced rate was low in both groups, gliclazide MR versus sitagliptin, 4.7 for gliclazide and 2.6 events per 1,000 patients a year. So the CPRD helped secure the place of newer generation sulfonylurea in modern type 2 diabetes management. Let us now discuss the end organ benefit and safety, cardiovascular safety. The newer generation sulfonylurea may be considered cardiovascular safe and are not associated with an increased cardiovascular risk compared with the standard therapy. So what we have learned from the advanced trial and the advanced on trial that people who were on the gliclazide MR intensive control group versus the other sulfonylurea, it showed that there is no increased risk for macrovascular event. There is no increased death from any cause and no cardiovascular death. In another study, Carolina, which in this study, they compared linagliptin versus glimepiride, and they found that both drugs were safe from the cardiovascular point of view. So that makes the second generation sulfonylurea, like gliclazide and glimepiride, has low risk for cardiovascular related mortality. And on top of the list, gliclazide followed by glimepiride. In regard to the other cardiovascular safety, the newer generation sulfonylurea may be considered cardiovascular safe and are not associated with increased cardiovascular risk. Sorry, this is a repetition of the slide. So now let us discuss the renal benefit. Several publications have confirmed the renal benefit with gliclazide MR-based intensive treatment versus standard therapy of other sulfonylurea. Again, in the advanced trial, it has been shown that there is a 14% reduction in the major microvascular event and 21% reduction in worsening nephropathy, and this is all statistically significant. In addition, there was 65% reduction in end-stage renal disease, as you can see here, and 9% reduction in albuminuria. And in the advance on trial, the post-trial follow-up, it has been shown that this renal protection has been sustained and there is continued 46% reduction in end-stage renal disease risk, which is statistically significant. So other groups such as the Association of British Clinical Diabetologists only recommended the use of one sulfonylurea, which is gliclazide, but do not recommend sulfonylurea used in type 2 diabetes when the GFR is less than 30. In regard to hypoglycemia and Ramadan, among sulfonylurea drugs, gliclazide poses the lowest risk of major hypoglycemic episodes comparable to risk level of other commonly used second-generation sulfonylurea agents. Hypoglycemia risk is a major concern in type 2 diabetes patients choosing to fast during the holy month of Ramadan and was examined in 3 main studies. The first study in 2011 by Servier et al., which looked at sitagliptin compared to sulfonylureas. In another study published in 2012 by Arvind et al., again sitagliptin versus sulfonylurea, and in 2020 by Hassanein et al., looking at gliclazide MR in Ramadan. So what was the result? In the Servier et al., he's shown that the symptomatic hypoglycemia occurred in 6.6% in people on gliclazide versus 6.7% in people on sitagliptin. In the Arvind et al., he showed that hypoglycemia occurred in 1.8% in gliclazide group as compared to 3.8% in sitagliptin group. So you have seen the safety of sulfonylurea is not uniform, and gliclazide, as has been shown, is associated with a lower hypoglycemia rate than other sulfonylureas and similar or even better rate than sitagliptin. In Hassanein et al., the Ramadan study, it was found that the overall risk of one or more symptomatic hypoglycemic event is 2.2%, and there was no severe hypoglycemic events occurred over the 14 to 18 weeks study period. In regards to body weight gain, there is no evidence of body weight gain due to sulfonylurea treatment, particularly gliclazide, and analysis of gliclazide recipients in the advanced trial-based medication type and baseline glycemic control found that participants already undergoing progressive titration of gliclazide, an approach consistent with the actual clinical real-life practice, showed no body weight gain. And the study participants lost even weight. As you can see here in the Easy Diet study, people with diabetes have lost weight between 0.9 to 2.2 kilogram, and the higher is the BMI, is the higher the loss of body weight. In addition, also in the Diet Ramadan trial, they found that people even lost weight with gliclazide, and as you can see here, between 0.5 to 3.9 kilogram with gliclazide. So should sulfonylurea remains an acceptable first-line add-on to metformin therapy in patients with type 2 diabetes without real or renal or cardiovascular risk or disease? The answer is yes. They continue to serve us very well, and the place of sulfonylurea with current guidelines, the guidelines recommendation about sulfonylurea as a class. I'm going to discuss it in the next coming few slides. As you can see here in the UK, NICE recommendation 2020, sulfonylurea remain a drug of choice for first-line intensification and second-line intensification and as add-on to metformin and other drugs. And the only sulfonylurea that has been recommended in UK NICE guideline is gliclazide and gliclazide MR. So NICE sulfonylurea may be considered if symptomatic first and second intensification, gliclazide or gliclazide MR. Again, in the Australian algorithm 2020 for the management of diabetes, sulfonylurea still also plays a major role as first line, second line, and third line recommendations in the management of diabetes, and it's used more commonly than other drugs, as you can see here. Again, in the ACE glycemic control algorithm 2020, after addressing the cardiovascular and renal issues and safety and benefits, sulfonylurea remain one of the drugs that may be used with caution as first and second line to achieve target A1C. In the latest also ADA and ASD consensus statement, after addressing again the cardiovascular and renal benefit, sulfonylurea remain one of the drug if cost is a concern, and also if A1C is not achieved, it may be used as an add-on drug to other classes of drug. And they considered to choose a later generation sulfonylurea to lower the risk of hypoglycemia. And they mentioned in the ADA, the glimepiride, which have shown similar cardiovascular safety to the DB4 inhibitor. Gliclazide is not available in the USA, so it is not seen in their guidelines and recommendations. So ADA, ASD, sulfonylurea is to be considered as first line if cost is a major issue, and second line after addressing other concerns. Also in the Diabetes Care 2014, they have wrote a sentence that the ideal anti-hypoglycemic agent would be easy to administer, unlikely to cause symptomatic side effect, and both barriers to adherence, inexpensive, reliably efficacious, and safe. And by such standards, it can be argued that the remaining modern sulfonylureas do well. So even the ADA recommends sulfonylurea as a good and effective and inexpensive drug. So the current evidence and recommendation would suggest that in the absence of atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure, a later generation sulfonylurea like gliclazide and glimepiride is still the most cost-effective first-line add-on to metformin and second-line agents for those patients, even in the first ward setting. Several international guidelines still recommend the use of modern sulfonylurea in patients with type 2 diabetes, even with in the presence of cardiovascular risk, because as I have shown you, it demonstrates cardiovascular safety. So sulfonylureas, a proven and still valuable option, still occupies a central position in the recommendation of all the guidelines for treatment of type 2 diabetes and are likely to continue to be a reliable and effective treatment, particularly as combination therapy. So in conclusion, ladies and gentlemen, the glucose-lowering potency of newer generation sulfonylurea is similar to older sulfonylureas, with the advantage of faster glycemic control and a lower incidence of adverse event. And most endocrinologists in the region, including the experts in the therapeutic areas who were involved in the present consensus, are fully aware that not all sulfonylurea drugs are the same, and they continue to prescribe sulfonylureas, especially gliclazide MR, as one of the top options for second-line treatments in patients with no known cardiovascular and renal disease. With that, on behalf of the primary author and my dear colleagues, the co-authors, I would like to thank you for attending. Thank you very much.